Imagine this scenario. You're standing in a hospital room, maybe you're chatting with a patient, or maybe you're just checking a chart, and suddenly the background hum of the room completely changes.
Hmm.
The rhythmic beep of the monitor it stops, or worse, it turns into this high-pitched screaming alarm.
Oh, yeah. It is the sound that every clinician dreads. But it's also what they train for. The atmosphere in that room shifts instantly. You go from routine maintenance to just absolute high-stakes
Right?
chaos.
It's a code blue. People are rushing in. The crash cart is rumbling down the hallway like a
Like a freight train.
exactly like a
Hmm.
freight train, and everyone's eyes are glued to one single thing in that room: the monitor. Because in that moment, seconds aren't just a measure of time, they're literally the difference between life and death.
It is the ultimate pressure cooker. And, in that chaotic environment, there is this secret language being spoken. It's not spoken with words. It's spoken with these little squiggly lines on a strip of pink grid paper.
Yeah, we are talking about the EKG, the electrocardiogram, which, to the untrained eye, it basically looks like a seismograph during an earthquake, right? Just a bunch of scribbles.
Yeah.
But it is actually a highly precise map of the electrical activity of the heart.
It is, and today we aren't just going to skim the surface of that map. We are going to completely decode it for you. We're going to look at how you measure the terrifying silence between heartbeats using this microscopic grid, and how to spot the deadly rhythms that demand a shock, and
And perhaps most surprisingly, how your own brain might be tricking you into seeing things that aren't even there.
right, cognitive bias in the ER. It's a huge factor.
It is going to be a fascinating ride today. And before we jump right into the grid, I do want to mention that this deep dive is brought to you by Whole Life Healthcare's EKG Lab Live podcast. If you really want to immerse yourself in the day-to-day reality of cardiac care, that is absolutely the place to go.
Oh, definitely. It's a fantastic resource for anyone in the field who wants to hear real cases broken down in real time.
So let's unpack this. We usually think of the heart in terms of beats, right? Thump, 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 thump. But you're telling me that one of the most critical skills is measuring what happens when the thumping actually stops.
That's right. We're going to start with what I like to call the ruler of the heart. It's the math of the pause. Because when you look at an EKG strip, you're looking at a grid. It's just like graph paper. And to a cardiologist or an ER nurse, that grid isn't just background noise. It is literally a ruler for time.
Okay, let's break that down. I want to get really granular here for a second. Let's pretend I'm back in third grade. I'm looking at this pink paper. What am I actually seeing?
Okay, picture the paper. It's made up of boxes. You have these big boxes outlined with heavy lines, and inside those you have tiny, lighter boxes. This grid is the foundation of everything we do. So we need to zoom in on that tiny, small horizontal box.
The absolute smallest unit on the page.
That one small horizontal box represents exactly 0.04 seconds.
0.04 seconds. I mean, that is tiny. That's faster than a blink.
It is practically microscopic.
Yeah.
But it's the constant. No matter what is happening, that small horizontal box is always 0.04 seconds. Now, if you look at the larger box, the one with the thicker lines, it is made up of 5 of those small boxes going across.
Okay, simple math time for me. 5 times 0.04, that gives us 0.20 seconds.
You've got it. So a small box is 0.04. A large box is 0.20.
Why does this level of precision even matter? I mean, are clinicians really measuring heartbeats down to the hundredth of a second in an emergency?
Well, when the heart is beating normally, no, not really. You can just sort of eyeball the overall rate. But sometimes the heart takes a break. The line goes completely flat. And the length of that break, the duration of the pause, tells you if the patient is just having a momentary glitch or if their natural pacemaker has completely failed.
So you are literally measuring the silence. How do you actually do that in the middle of a busy shift? Walk me through the protocol.
There is a very specific, systematic way to do this. First, you have to locate the pause. You look at the strip and find the last normal wave before the line goes flat. Usually that's the P wave, the little bump before the big spike, or the QRS complex itself. That is your starting point.
Okay, so starting point is found, the last normal beat.
Exactly. Then you scan across the flat line until you see the very next P wave or QRS where the rhythm finally starts up again. That is your endpoint. You are measuring the distance between the last beat and the next beat.
Got it, start point to end point. But how do we physically measure that distance?
In an ideal world, you'd use a pair of calipers. Those are the little compass-like tools that architects use, so you can be completely exact. You'd place the metal tips on the start and end points and pull it across the grid.
Note to self, always carry drafting tools to a dinner party just in case. But let's be real, most of us probably don't have calipers in our pockets in the back of an ambulance.
Right, which is exactly why you use the grid. You count the boxes. This is count the small boxes method. You literally count every single tiny box between those 2 points on the paper.
That sounds incredibly tedious, but let's say I do it. I count the small horizontal boxes. Then what?
You take that number and you multiply it by our magic number, B0.04.
Can you give us an example? Let's say I'm looking at a strip. There is a long, scary silence, and I count, let's say, 75 small boxes.
Okay, perfect. Take 75, multiply it by 0.04. What do you get?
That would be 3.0 seconds.
Exactly. 3 seconds of silence.
3 seconds feels like an absolute lifetime when you're standing over a patient watching a heart monitor.
It really does.
Yeah.
Now, if you want a faster method, a quick estimation, when you don't have time to count 75 tiny squares, you can use the large box method as an alternative. Remember, each large horizontal box is 0.20 seconds.
Right, so I just count the big, thick squares and multiply by 0.20.
Yes, exactly. It gets you to the exact same calculation, just with less squinting.
So we have the number, we've done the math, and we have a 3-second pause. What does that actually tell us? Is there a clinical cutoff for when we should start to panic?
There are strict definitions we use to communicate severity. Generally, if that failure of impulse formation lasts less than 2.0 seconds, we call it a sinus pause. It's basically a hiccup. The heart missed a beat, but it kicked right back in.
Okay, so a sinus pause is less than 2 seconds.
But if that cessation of activity from the SA node, which is the heart's natural pacemaker, if that lasts longer, usually defined as greater than 3 seconds, we call it a sinus arrest.
Arrest. That word carries a lot more weight.
It does. A sinus arrest is a much more significant failure. It means the generator essentially shut down. And according to the University of Virginia School of Medicine sources we pulled for this deep dive, recurrent pauses of 3 seconds or more, or really any pause that causes symptoms like dizziness or fainting, requires immediate clinical investigation.
But wait, there is a nuance here that I found in the source notes that I think is fascinating. It's a measurement tip that completely changes the diagnosis. It's called the exit block.
Oh, yes, I love that you caught this, because this is where the math really proves its worth. Sometimes that long silence isn't an arrest at all.
How can you tell the difference?
You have to look at the rhythm before the pause happens. You measure the distance between the normal beats, we call that the P to P interval, get that normal timing in your head.
Okay, so I figure out the normal beat length first.
Right. Now look at the pause itself. If the total length of that silence is an exact multiple of the normal interval, say, the pause is exactly 2 times the length of a normal beat, or exactly 3 times the length that isn't an arrest.
Wait, so if the pause fits the underlying mathematical pattern perfectly, it means something completely different.
Exactly. It implies the pacemaker was actually firing on time in the background, the generator was working perfectly, but the signal just didn't get out of the SA node box to the rest of the heart muscle. We call that an SA exit block.
That is wild. It's like the signal is knocking on the door on time, but the door is jammed shut.
Precisely. It's a conduction problem. The door is jammed. It's not a formation problem with the generator. And you would never know the difference if you didn't do the precise math with the grid.
So measuring to the 100th of a second isn't just busy work. It actually changes the entire diagnosis. But I still have to say, trying to count 75 tiny boxes on a moving strip without tools sounds like a recipe for a massive headache.
Oh, it is a nightmare. You're squinting, your eyes cross, you lose count halfway through. It's really not fun.
Which brings up a great point for you listening. If you don't have a pair of calipers handy to measure those P waves, and you're tired of squinting at 0.004 second boxes, you should really check out our EKG survival kit. It's an absolute lifesaver for keeping your measurements straight in a high-stress environment.
It is absolutely essential gear. Every nurse or medic should have one.
And hey, for more audio guides like this one, where we break down the really complex stuff, make sure you find our location on, wait for it, Spotify.
Did you just say Spotify again?
I did. Yeah. That's where the cool kids hang
Yeah.
out, right? Spotify. Anyway, check the show notes for the link.
Let's please move on.
Fine, moving on. So we've measured the silence. We have the math. Now let's jump back to that code blue scenario we started with. The alarms are blaring. You do not have time to count 75 tiny boxes. You need to know right now, is this patient going to make it? What do you do?
Right. In a code blue, the priority shifts completely. You're the nurse or the doctor at the bedside. The first question isn't how long is the pause. The first question is entirely binary. Do I shock this patient or not?
Shockable versus non-shockable rhythms.
Yeah.
This seems like the most critical decision tree in all of emergency medicine.
It absolutely is. Let's talk about the shockable ones first. These are the rhythms where a blast of electricity can actually reset the heart. The big one is ventricular fibrillation, or VFib.
I've heard this described in the literature as looking like a bag of worms.
That is a very accurate, if slightly gross, visual. On the monitor, V-fib looks completely chaotic. There are no clear spikes, no recognizable P waves or QRS complexes, just our regular wandering waves. It's jiggly bits, to quote a common ER mnemonic. The heart muscle is just quivering uselessly. There is zero cardiac output.
So the patient is functionally dead unless you act right then.
Correct. The priority here is immediate defibrillation, shocking them, and high-quality CPR. You shock that chaos to try and force it to reorganize. The other shockable rhythm is pulseless V-touch. That's where you see wide, extremely rapid spikes. It looks almost like a row of shark teeth or a jagged picket fence.
But the key word there is pulseless.
Yes, vitally important. The monitor shows these big, organized-looking waves, but the heart is beating so fast it isn't actually filling with blood, so the patient has no pulse. You shock that immediately.
Okay, so shocking makes total sense there to reset the rhythm. But what about the ones you don't shock? Because I feel like TV shows and movies always get this completely wrong. They see a flat line on the monitor, the doctor yells clear, and they shock the patient.
Oh, that is my biggest medical pet peeve. It makes me want to throw my shoe at the television. The flat line is called a systole. There is absolutely no electrical activity happening in the heart.
So why don't we shock it? Wouldn't a massive jolt of electricity jumpstart it? Like a car battery?
No, the heart isn't a car battery. A defibrillator shock works by simultaneously stunning all the heart cells that are already firing chaotically, hoping they wake up together in a normal rhythm. If there's no electrical activity at all, you are just burning dead tissue. You never shock a systole. The priority is CPR and pushing epinephrine to try to create a chemical spark first.
Okay, so flatline equals no shock. What is the other non-shockable rhythm?
This is the real trickster of the bunch. It's called PEA, which stands for pulseless electrical activity. This is where the monitor shows an organized rhythm. It might even look exactly like a normal, healthy heartbeat on the screen.
Wait, the monitor looks totally normal, but the patient doesn't have a pulse.
Exactly. The electrical system is firing perfectly, but the physical pump, the heart muscle itself, isn't responding. This is why we relentlessly tell nurses and medical students, treat the patient, not the monitor. If you just look up at the screen, you might think they are doing fine. But if you touch their wrist or their neck and there is no pulse, it's a full code blue.
That is, frankly, terrifying. You have to physically check the human being, not just trust the machine.
You have to. And in that situation, the nurse's role is absolutely vital. The source materials emphasize this heavily. Do not wait for the crash cart to arrive. If you identify these rhythms or you find a lack of pulse in PEA, you start chest compressions immediately. The nurse has to be the one to compress, analyze the rhythm quickly, and call out the findings clearly so the rest of the team knows exactly what algorithm to follow when they run in.
So we've covered the immediate life or death crash scenarios. But sometimes you have a little bit more time to actually look at the pink grid paper. You're playing detective. You're looking for the clinical story behind the squiggles.
Right. This is where we get into systematic interpretation. The routine is usually rate, rhythm, axis, intervals. You follow the sequence so you don't miss anything. But more importantly, we look for specific visual patterns that tell us the patient's medical history without them ever having to say a single word.
I really love these buzzword diagnoses. Let's run through a few of the fascinating ones from our sources. Tell me about the medical student who drank way too many energy drinks.
Ah, yes, the classic textbook case. A young person, maybe 23 years old, super stressed out studying, massive caffeine overload, and they come into the ER with a racing heart. You print out the EKG, and you see this swooping upslope right at the beginning of the QRS complex. We call it a delta wave.
What does a delta wave actually look like to a layperson?
It looks exactly like a shark fin rising out of the water before the big spike.
And what does that shark fin mean?
It indicates Wolff-Parkinson-White syndrome, or WPW. It means they were born with an extra abnormal electrical pathway in their heart. They might have gone their whole life not knowing, but the massive dose of caffeine just triggered it to short circuit.
Shark fins seem to be a recurring theme in cardiology, because I saw another one in the notes called Brugada syndrome.
Yes, Brugada is a scary one. It's a rare genetic condition that can cause sudden cardiac death in otherwise healthy people. On the EKG, you see this coved ST segment elevation, specifically in leads V1 to V3. And again, it looks remarkably like a shark fin. If you see that pattern, that patient needs an electrophysiologist immediately.
Okay, let's pivot to diet for a second because I found this fact in the UNC slides absolutely hilarious. We always tell people to eat bananas for potassium, right? That's the common wisdom.
Right, and potassium levels are critical because low or high potassium severely messes with the heart's electrical gradient. If your potassium is way too high, a condition called hyperkalemia, you get these massive peaked T waves on the grid. They look like tall, sharp camping tents.
But the fun fact in the sources is that bananas aren't actually the kings of potassium.
They really aren't. It turns out avocados, guavas, and kiwis actually have significantly more potassium per 100 grams than bananas do. So if you see those giant peaked T waves, maybe ask the patient if they've been going incredibly heavy on the guacamole lately.
See, that is the exact kind of medical trivia I live for. Okay, one more specific pattern, the basketball player.
This one is tragic but so important to recognize. Imagine a young athlete, super fit, playing a game, and they just suddenly collapse in the court. On their EKG, you might see these deep, narrow, dagger-like Q waves. It strongly suggests HOCM, which is hypertrophic obstructive cardiomyopathy. Basically, the heart muscle has grown far too thick and it obstructs the blood flow during intense exercise.
It's amazing to me how specific these visual clues are. A shark fin, a dagger, a camping tent. It really is a distinct visual language.
It is, and this is a massive, but our ability to read that visual language is incredibly flawed. And it's not because the grid paper is wrong. It's because our human brains are heavily biased.
Which brings us perfectly to the final segment on the human factor. We tend to have this idealized idea that doctors are like computers. They see the data, they process the data, they output the correct diagnosis, but the cognitive research says otherwise entirely.
Absolutely. We rely on two primary systems of thinking. System one is your fast, reflexive, heuristic instinct, your gut feeling. In the ER, clinicians use system one a lot because they simply have to save time. System two is your slow, analytical, deliberate thinking process.
So the common wisdom in medicine has always been, if you want to avoid diagnostic errors, just slow down. Engage system two. Look at the grid carefully.
That is the common wisdom, yes.
Oh.
But the research suggests it's largely a myth. A systematic literature review found that simply telling doctors to slow down and be thorough did not necessarily improve their diagnostic accuracy at all.
Wait, really? Slowing down didn't actually help them find the right answer?
No, it just meant they spent significantly more time getting to the exact same, sometimes incorrect, conclusion. But what did significantly change their accuracy was the patient's story attached to the EKG.
This is the Australian study from the source material, right? Because this study blew my mind.
Yes. Researchers took a group of doctors, ranging from brand new interns all the way up to senior specialists, and they gave them a set of EKGs to read. Some of the EKGs came with what they called a positively biased history, meaning a story that pointed toward the right answer. For example, giving them an EKG showing a heart attack and telling them the patient was an older man with crushing chest pain.
And I assume they did well on those.
They did great. Their accuracy went way up. But then the researchers gave them negatively biased histories. They took a clinically significant, dangerous EKG, but attached a story that strongly suggested something minor, like handing them a heart attack EKG but saying, this is a 28-year-old patient who just has a viral illness and a slight fever.
And what happened?
Their diagnostic accuracy absolutely plummeted across the board. Even the senior experts were swayed. They looked at the exact same squiggly lines, the exact same mathematical grid we just spent this whole time talking about, but because the narrative said viral illness, their brains quite literally filtered out the heart attack data on the page.
That is genuinely frightening. We literally see what we expect to see, regardless of the objective data in front of us.
We really do. We do not read EKGs in a vacuum. The narrative totally frames the data. If the triage nurse says, I think it's just a panic attack, you are statistically far less likely to see the deadly arrhythmia on the page.
So what does this all mean for you listening to this? We started today with the absolute microscopic precision of the small box. 0.04 seconds. Pure math. Objective truth. And we ended with the idea that a simple, misleading sentence from a patient can completely blind a trained expert to that truth.
I think it means that being an expert clinician isn't just about knowing the rules of the EKG grid. It's about knowing the rules and the flaws of your own mind. You have to intentionally separate the data from the narrative. You have to trust the math.
Trust the calipers. Or at least the count the boxes method.
Exactly. When in doubt, go back to the small box. Let the math speak first.
Let's recap the big takeaways for today's session.
First, respect the grid. Remember the rule of 0.04. One small horizontal box is 0.04 seconds. One large box is 0.20 seconds. If you see a pause, count the boxes and do the math. If it's less than 2 seconds, it's a sinus pause. If it's more than 3 seconds, it's a sinus arrest, unless it's an exact multiple of the normal beat, and then you know it's an exit block.
Second, know your code blue rhythms cold. V-fib and pulseless V-touch get the shock. Asystole and PEA absolutely do not. And with PEA, remember the golden rule. Treat the patient, not the monitor. Physical pulse checks are mandatory.
And finally, be fiercely aware of your own cognitive bias. A convincing, positively biased story helps, but a negatively biased story can make you miss a deadly diagnosis. Force yourself to look at the objective lines first before you let the story take over.
The lines don't lie, but the story definitely might.
Perfectly put.
Well, that wraps up this deep dive into the electric language of the heart. A huge thank you to Whole Life Healthcare's EKG Lab live podcast for making this incredibly important conversation possible.
Definitely check them out. It's a great show.
And please don't forget to look for our EKG survival kit if you are tired of counting those microscopic boxes with your naked eye. You can find us and all of our other audio guides on Spotify.
You're really never going to say that right, are you?
Nope. Spotify. I am staying with it. But here's a final thought for you to chew on as we go. We talked extensively today about how simply slowing down doesn't actually fix our diagnostic errors. And we saw how a misleading patient story can blind highly trained experts to what is mathematically right in front of their eyes. If that is all true, how do we actively train our brains to silence the compelling human narrative and only trust the cold, hard grid? Is it even truly possible for a human being to be perfectly objective when another human life is the variable sitting right in front of them?
Now that is the ultimate question for medicine.
Thanks for joining us. We'll see you in the next deep dive.